Good evening, everybody. I am Dr. Shari Silva, Senior Registrar in Family Medicine. Today, I am going to conduct this MCQ session under the guidance of Dr. Markanti Galhene, Consultant Family Physician. Today, we mainly focused on ENT MCQs. If you get any questions or any doubts during the session, do not hesitate to ask questions. So, Markanti Madam also here to help us today. This is our first question. I will give 1 minute to prepare for this. Which one is true or false regarding BPPV or benign paroxysmal postural vertigo? Anyone can answer the question. The EPI manual is used in primary care to diagnose BPPV. Second one, vertical nystagmus is a feature of acute attack. Third one is each episode lasts around 10 to 20 seconds. And next one, vertigo is triggered by exertion. Beta histine is effective treatment for BPP. Okay, so before going to see the answers, we discuss what do you mean by vertigo. So actually, in our day-to-day practice, vertigo is a very common presentation. Patients use a common singular term of Karakavilla to describe spinning sensation, lightheadedness, faintishness, dizziness, and for real vertigo. And so it is our responsibility, doctor's responsibility to clarify what is the actual complaint of the patient. It is important to decide the suitable management plan. So vertigo is a symptom of vestibular dysfunction, and it is a sensation of motion, most commonly rotational motion of surrounding environment. And it is not lightheadedness or dizziness. The rotational motion of surrounding environment is a key feature. And vertigo can be due to peripheral lesions or problem with inner ear. And vertigo may be origin of the central lesions, or the origin is from the brain. These are the common peripheral causes for vertigo. Benign paroxysmal postural vertigo, Meniere's disease, acute labyrinthitis, vestibular neuritis, herpes zoster oticus or Ramsay Hunt syndrome, cholesteatoma, otosclerosis, and perilymphatic fistula. The central causes of vertigo mainly stroke, ischemic or hemorrhagic stroke, involving the cerebellum or vertebro-basilar system. And cerebellopontine angle tumors also the cause for central type of vertigo. And vestibular migraine is another cause for central origin of vertigo. And multiple sclerosis is another cause. So these are the common causes of vertigo we meet in our day-to-day practice, and their main features. Viral labyrinthitis or inflammation of the labyrinth. Patients present with recent viral infection and the sudden onset of vertigo with nausea and vomiting. This is very important feature of viral labyrinthitis. The hearing impairment is there. So vestibular neuritis or inflammation of vestibular nerve. Patients present with similar way like viral labyrinthitis with recent history of viral infection, recurrent vertigo attacks, usually lasting hours or days. But patients with vestibular neuritis, they do not have hearing impairment. So this feature is important to differentiate viral labyrinthitis from vestibular neuritis. And BPPV, another most common cause in primary care, patients present with vertigo. So this is benign condition. Patients present with brief episodes of vertigo triggered by changing head position. And this is due to floating of calcium deposit or debris in posterior semicircular canal. And they have brief history of vertigo. Each episode lasts 10 to 20 seconds. And Meniere's disease is another cause for vertigo. Patients present with progressive type of hearing loss. This is actually actual reason we do not know, but it says that increased volume of end lymph in the semicircular canal is a cause for this problem. And it is associated with hearing loss. It is progressive type, tinnitus or ringing ear, and sensation of fullness or pressure in one or both ears, last minutes to hours, commonly around 20 minutes. And vertebrobasilar insufficiency. Usually elderly patients, when they come with the vertigo, we have to exclude this condition. The patients complain about the vertigo on extension of neck. This is maybe due to the degenerative changes of the neck bones and osteophyte formation and bone spurs, the compression of the common arteries, which supply blood to the brain, and sometimes may be due to the atherosclerosis of the main arteries. The acoustic neuroma is another cause of vertigo. Patients present with unilateral hearing loss, vertigo, and tinnitus. This is an important feature of acoustic neuroma. It is absent corneal reflex. And usually this condition is associated with neurofibromatosis type 2. As I told you, vertigo can be due to central lesions and peripheral lesions. Central lesions we see bidirectional, vertical, or any direction of nystagmus. But in peripheral lesions, often presents with horizontal nystagmus with a torsional component. Actually, you can't see purely torsional or vertical nystagmus in peripheral origin of vertigo or problems with inner ear. You can't see vertical nystagmus or purely torsional nystagmus. Actually, the modality of choice of investigation of central lesions is MRI or magnetic resonance angiogram, because CT scan is less sensitive test to diagnose and evaluation of central lesions or central origin of vertigo. Benign paroxysmal positional vertigo, it is, as I told you, it is very common presentation in our day-to-day practice. And patients usually present at the age of after 55 years, but it can happen to patients with any age, but it is less common in younger patients. The onset is sudden and triggered by the change in head position. Example like rolling over in bed in the morning and gazing upwards. Patients usually complain about the nausea during the attack, and this each episode is brief, typically lasts 10 to 20 seconds. And the diagnostic test is positive disc pulpite manuals. This is diagnostic test. And Epli-manuals is a treatment for BPPV. It is actually effective for 80% of cases presents with BPPV. And sometimes we prescribe medications for BPPV like beta-histine, but actually it has limited value. The Epli-manuals is the most effective treatment for BPPV. So these are the answers for our first question. So BPPV, the Epli-manuals is used in primary care to diagnose BPPV. It is false because Epli-manuals is used for treatment of BPPV, not to diagnose. And vertical nystagmus is usually feature of central origin of vertigo, not a feature of BPPV. And each episode lasts 10 to 20 seconds. It is true. And vertigo triggered by exertion, it is false because vertigo in BPV triggered by change in head position. And beta-histine is effective treatment. It is false because effective treatment is Epli-manual. So, do you want to ask any questions or do you want any more explanation for this question? Then next, next question is, which one of the following is true or false regarding vertigo? So I will give 1 minute to prepare for this question. Which one of the following is true false regarding vertigo? The Hints test must be performed on patients suspected of central vertigo with persistent symptoms. The next question is, the next answer is, the nystagmus is central vertigo is always unidirectional, often with rotatory element regardless of the patient's gaze direction. And the next one is, central vertigo is the most predominant symptom of posterior circulation stroke. The next statement is, vestibular migraine is a cause for central vertigo. The last sentence is, patients with vertical nystagmus can be reassured. So, if you can answer for this question. The Hints test means it is the collection of the first letters of head impulse, nystagmus, and test of skew. Actually, sometimes we find it difficult to decide whether the vertigo is central or peripheral. So at that time, in a primary care setup, Hints test is useful test. It is a neurological examination actually. We use it to diagnose or exclude central etiologies of vertigo. We should perform this test for patients with ongoing acute spontaneous vestibular symptoms or ongoing continuous symptoms of vertigo, gait, unsteadiness, nausea, and vomit. And we see three things in this test: head impulse test, nystagmus, and test of skew. Head impulse test, we look for a rapid movement of the eye between fixation point. So the abnormal results or positive results we can see in peripheral origin of vertigo, but not central. So abnormal results or positive results of head impulse test we can see in patients with peripheral type of vertigo. And the next one, nystagmus. We see unidirectional nystagmus. It is reassuring thing because it is most likely due to the peripheral origin of vertigo. So bidirectional or vertical type of nystagmus is most probably due to central origin, but unidirectional nystagmus is most likely due to peripheral origin of vertigo. So when nystagmus changes the direction, or if it is vertical, most likely due to central pathologies. As I told you, bidirectional nystagmus is highly specific for stroke. The next one is test of skew. The presence of vertical skew is highly suggestive of central cause. Actually, to get a better understanding about the hints test and to learn how to perform that, there are YouTube videos are there. So I have mentioned a link here in the next slide. Please go through that so you can get a better understanding about the hints test. So this is the summary of hints test. In peripheral lesions, head impulse is abnormal, but it is normally central origin of vertigo. And nystagmus is in peripheral causes, maybe no, or maybe unidirectional. And central type of origin of vertigo shows nystagmus of bidirectional or vertical nystagmus. And test of skew in peripheral origin of vertigo, there is no vertical skew. And in central origin, there is a vertical skew, we can see. So this is one of the videos, so you can go through that, so you can get a better understanding about the hints test. So vestibular migraine is also not an uncommon presentation to our primary care setup. Patients usually present with migraine attacks as usual migraine attacks like headache with unilateral type of headache with pulsating quality and with moderate or severe pain intensity. And they complain of triggering factors like menstruation, physical and emotional strain, starting of oral contraceptive pills or sleep deprivation or missed meals like that. And it is usually associated with photophobia and phonophobia. And patients complain the features of visual aura. And there are diagnostic criteria of vestibular migraine, like there should be at least 5 episodes with vestibular symptoms of moderate or severe intensity, lasting 5 to 72 hours. And current or previous history of migraine with or without aura. And one or more migraine features with at least 50% of vestibular episodes. So these three are the one of the diagnostic criteria of vestibular migraine. So usually we have to refer these patients to neurology for neurology opinion, to get neurology opinion. So these are the answers for the second question. The hints test must be performed on patients suspected of central vertigo with persistent symptoms. It is true. And we use that to exclude or diagnose central origin of vertigo. The nystagmus in central vertigo is always unidirectional. So it is not a correct statement because the nystagmus in central vertigo is usually bidirectional or vertical. And central vertigo is the most predominant symptom of posterior circulation stroke. It is true. The posterior circulation stroke, the patients usually present with vertigo. It doesn't show the features of other type of stroke like weakness and reduced sensation, those things, but they usually present with vertigo. And vestibular migraine is a cause for central vertigo. It is true. And patients with vertical nystagmus can be reassured. It is false because vertical nystagmus is a feature of central origin. So this statement is false. Next question is, which of the following statement is correct concerning tinnitus? So we try to find the answers all together. Tinnitus is the perception of sounds in the ears or head that come from an outside source. What do you think? And magnetic resonance angiography is often used to investigate pulsatile tinnitus. Captopril can be a common cause of tinnitus. What do you think? True or false? Cognitive behavior therapy is useful for some patients. Generally, non-pulsatile tinnitus does not require imaging. Okay, if anyone can answer this question. Okay, tinnitus or ringing ear. Tinnitus is the perception of sounds in the ears or head that do not come from an outside. The problem within the inside the problem, not sounds do not come from outside. And not all patients will require imaging. So non-pulsatile tinnitus does not require imaging because the tinnitus, it has wide range of causes. Most of the causes are self-limiting and benign causes are there. So always do not require any imaging unless if the tinnitus is unilateral or it associated with neurological signs. At that situation, we have to perform MRI imaging, MRI scan. So MRI angiography, it's sometimes the tinnitus, it has a pulsatile quality. If it is there, it is maybe due to vascular origin, vascular malformations, or aneurysm-like conditions, or due to hypertension. So at that time, we have to evaluate those patients and we have to refer them for neurology opinion. So causes of tinnitus. These are the main and common causes of tinnitus. Meniere's disease, patients present with hearing loss or maybe fullness of ear or pressure, feeling pressure in one or both ears with tinnitus and vertigo. Otosclerosis is another cause for tinnitus. Onset is usually at around 20 to 40 years young age group. And there is a hearing loss. It is a conductive type of hearing loss and also associated with tinnitus. In this case, majority of patients have a normal tympanic membrane, but 10% of patients may have a flamingo tinge due to the hyperemia of around the tympanic membrane. And there is a positive family history. This condition is inherited as autosomal dominant manner. Acoustic neuroma also presents with tinnitus, usually unilateral type of tinnitus with unilateral hearing loss and vertigo. and absent of corneal reflex. And there is association with neurofibromatosis type 2. And excessive loud noise or elderly patients with presbycusis also presents with tinnitus with gradual progression of hearing loss. Impact with earwax can cause tinnitus, usually associated with conductive type of hearing loss. And sometimes it is due to idiopathic or no cause found. It is a common cause for tinnitus. So sometimes drug also can cause for ringing ear, furosemide, aspirin, aminoglycosides, acids, quinine are common drugs related with tinnitus. So these are the answers for that question. Which of the following statement is correct concerning tinnitus? Tinnitus is the perception of sounds in ears or head come from an outside. It is false. And magnetic resonance angiography is often used to investigate pulsatile tinnitus. It is true. To exclude vascular origin of for tinnitus. And captopril is a common cause of tinnitus. It is false. Actually, captopril is not a common cause of tinnitus. But there are other drugs like furosemide, aspirin, aminoglycosides, acid, and quinine. So you can get questions from that area. And the patients with tinnitus, actually, they have lots of psychosocial disturbances, and depression also common with patients with tinnitus. So we always have to screen them for depression, and we have to ask suicidal ideas from them. They have features of depression. So these patients, cognitive behavior therapy is useful for them. It helps them to improve their quality of life with this complaint of tinnitus. Generally, non-pulsatile tinnitus does not require imaging, it is true. But pulsatile tinnitus, you need further imaging to exclude vascular origin. The next question, or do you want to ask any questions from this area? What is true or false concerning cholesteatoma? It is a malignant condition with destruction of skull bone. Recurrent false swelling ear discharge is a common feature. Sensory neural hearing loss is a characteristic feature. Facial palsy is due to bone destruction. Attic lesion is otoscopic finding in the middle part of the eardrum. If anybody want to answer for this question. Cholesteatoma. It is non-cancerous growth. So it is not a malignant type of growth of squamous epithelium. Local destruction is there, but it is not malignant, but local destruction is there. Patients with born with cleft palate, this condition is common among the patients born with cleft palate. And main features of cholesteatoma is foul smelling, non-resolving discharge, and conductive type of hearing loss. And other features due to local invasion like vertigo, facial nerve palsy, or cerebellopontine angle syndrome. So otoscopic finding of attic lesion or attic crust seen in uppermost part of the eardrum, not the middle part of the eardrum. It is common in uppermost part of the eardrum. And the management of cholesteatoma, if we diagnose these patients in our primary care setup, we have to refer them to ENT to get surgical opinion, or surgical removal is the management of cholesterol. This is a picture of cholesterol. So I think you can see this is the lesion. So answer for this question, it is malignant condition with destruction of the skull bone. Destruction of skull bone is correct, but it is not malignant condition. So it is false. Recurrent false meaning ear discharge is a common feature. It is true. Sensory neural hearing loss is a characteristic feature. It is false. Hearing loss is there, but it is conductive type. Facial palsy is due to bone destruction. It may be true. Attic lesion is prominent otoscopic finding. It is true, but it is in the uppermost part of the eardrum, not in the middle part. So it is false. Fifth question, which one of the following statement is true or false? We'll try to find the answers altogether. Intranasal steroid therapy is effective treatment for 4 months history of nasal congestion affecting right nostril. It means unilateral part. What do you think? A topical antibiotic and steroid combination would be appropriate management for otitis media. Topical antibiotic and steroids for otitis media. And chronic suppurative otitis media is defined as perforation of tympanic membrane with otorrhea for more than 2 weeks. Sudden onset sensory neural hearing loss requires urgent referral to ENT. Hearing loss can be a feature of viral labyrinthitis. Can someone answer for this question? We see the explanations. Nasal polyps. So also a common presentation to our primary care. So you can get questions from this area as well. The associations of nasal polyps like bronchial asthma, aspirin sensitivity, infective sinusitis, cystic fibrosis, cartilaginous syndrome, and Church-Strauss syndrome. So sometimes they may ask question from this area. And nasal polyps, features of nasal polyps, the main complaint is nasal obstruction and rhinorrhea, sneezing, and poor sense of taste and smell. Unusual features like unilateral symptoms or bleeding. So we have to we need further investigations urgently if unilateral symptoms or bleeding is present. Anyway, all patients with suspected nasal polyps should be referred to ENT for full examination. And treatment is topical corticosteroids can shrink polyp size in around 8% of patients. Sometimes they need surgical removal of nasal polyps. And I think you need to read these areas like otitis externa and those parts, but I have touched very briefly and on the important points, but I think it's better if you can read around these topics. And management of otitis externa. We use topical antibiotic or combination topical antibiotic with steroid for management of otitis externa. If the tympanic membrane is perforated, we usually not use aminoglycosides traditionally. But if there is canal debris, we have to remove them. And insertion of earwig and administration of topical antibiotics and steroid is effective method in treating otitis externa. Chronic suppurative otitis media is a complication of unresolved acute otitis media with perforation. So acute otitis media with perforation may develop into chronic suppurative otitis media. So it defined as perforation of tympanic membrane with otorrhea for more than 6 weeks. Not 2 weeks, it is more than 6 weeks. So these are the common causes of hearing loss. We can divide it to conductive type of hearing loss and sensory neural type of hearing loss. These are the common causes of conductive hearing loss: otitis media, foreign bodies, otosclerosis, polycystoma, fluid in the middle ear, perforated tympanic membrane, and eustachian tube dysfunction. And sensory neural hearing loss can be due to presbycusis in elderly patients and Ramsey-Hunt syndrome and acoustic neuroma, Meniere's disease, acute labyrinthitis, exposure to loud noise, or maybe idiopathy. And if patients present with sudden onset of hearing loss, first, we have to differentiate whether it is conductive type or whether it is sensory neural hearing loss. If it is sudden onset of sensory neural hearing loss, we have to refer those patients urgently to ENT opinion, because it should be further evaluated, investigated. Sometimes those patients need MRI scan to exclude vestibular schwannoma. The majority of sensory neural hearing loss is idiopathic. In ENT units, they use high dose of corticosteroids or intratympanic corticosteroids to treat sudden onset of sensory neural hearing loss, and it is effective treatment for that condition. So remember that we have to refer those patients urgently to ENT. So answer for the fifth question: which one of the following statements is true or false? Intranasal steroid therapy is effective treatment for 4 months history of nasal congestion affecting right nostril. Actually, unilateral symptoms, we have to refer them to ENT for further evaluation. And treating them with keeping them in a primary care setup and treating with intranasal steroid therapy is not effective treatment. And a topical antibiotic and steroid combination would be appropriate management for otitis media. So we treat otitis externe, not otitis media, with topical antibiotic and steroid combination therapy. And chronic suppurative otitis media is defined as perforation of tympanic membrane with otorrhea for more than 4 weeks or 6 weeks, not more than 2 weeks. And it is false. Sudden onset sensory neural hearing loss requires urgent referral to ENT. It is true. And they treat them with intratympanic steroids, high dose of steroids. Hearing loss can be a feature of viral labyrinthitis. It is true. And it is sensory neural type of hearing loss. The sixth question is, which one of the following statement is true? Try to find the answers altogether. When investigating patients with hoarseness, a chest X-ray should be considered. Metastasis to the brain is common in malignant otitis externe. Sudden sensory neural hearing loss should be treated with low dose of prednisolone. Bone conduction better than air conduction in positive Rhine test. Last statement is, progressive hearing loss is a feature of Meniere's disease. Okay. Then Let's move to the explanations. These are the common causes of hoarseness of voice. There are many causes, but most common causes are voice overuse, smoking, and development of the laryngeal or throat cancers, viral illness, hypothyroidism, gastroesophageal reflux, laryngeal cancer, or lung cancers. And you can go through that. You may get questions from these areas as well. And malignant otitis externa. This is an uncommon type of otitis externa, but this is not a malignant disease. Even though there is a word of malignant, this is not a malignant condition. It is due to it's the one uncommon type of otitis externa. Usually, we see this condition in immunocompromised patients, most of the time with patients with diabetes, and most commonly caused by Pseudomonas aeruginosa. The infection in soft tissues and external auditory matters, and its progress to involve the soft tissues as well as bony ear canal. So it can cause or it can progress into the temporal bone osteomyelitis. This is the dangerous of this malignant otitis externa. So, as I told you, this is common in diabetic patients. Patients complain very severe and deep-seated otalgia or ear pain, temporal headaches, parodontophoria or ear discharge. And some may present with dysphagia, voice change, facial nerve dysfunction. And the otitis externa is a very common presentation in primary care, and we treat them effectively. But if you think, when you're treating the patients, if you think it is non-resolving otitis externa with worsening pain, always refer them urgently to ENT to exclude malignant otitis externa, because those patients need inward treatment with IV antibiotics. They need prolonged treatment of intravenous antibiotics to cover pseudomonal infection. The other condition, Meniere's disease. The patients with Meniere's disease usually complain about the excessive pressure and progressive dilation of the endolymphatic system. It is more common in middle age group patients, but you can see at any age. Patients complain about the recurrent episodes of vertigo, tinnitus, and hearing loss. The hearing loss is sensory neural type, and vertigo is usually the prominent symptom. And sensation of oral fullness or pressure is the most common complaint. And nystagmus also a feature. Episodes usually last minutes to hours, usually around 20 minutes. And symptoms are unilateral, but bilateral symptoms also can develop after a number of years. The hearing loss may be progressive. And psychological distress is also a common problem in this condition. Usually, we need to refer these patients to ENT assessment to confirm the diagnosis and hearing assessment. We have to, in primary care, as primary care physician, we have to advise those patients to not to drive during the attacks. And during acute attacks, we can treat them with prochlorperazine. To prevent the attacks, we can use beta-histine and vestibular rehabilitation exercises. Another condition associated with hearing loss, otosclerosis. This is a replacement of normal bone by vascular spongy bone. And the hearing loss in otosclerosis is conductive type. And this is familial condition, inheritance as autosomal dominant manner, and typically affects young adults. And conductive difference is there, and otosclerosis with hearing loss can be associated with tinnitus as well. And majority of patients have normal tympanic membrane, but 10% of patients may have a flamingo tinge caused by hyperemia. And positive family history is a feature due to autosomal dominant condition. So this is a picture. I think you can see flamingo pink. Then we'll talk a little about Rhine and Weber test in a primary care setup. This is very useful test to assess the hearing. We perform Rhine and Weber test to differentiate conductive hearing loss and sensory neural hearing loss. To perform this test, we need to use tuning fork. It is 512 Hertz tuning fork. But you should not use 128 Hertz or 256 Hertz tuning fork. These tuning forks we use to test vibration sensation in neurological examination. For hearing assessment, you need to use 512 Hertz tuning fork. Rhine test. When we perform Rhine test, we need to place tuning fork over the mastoid process. And positive test means air conduction is better than bone conduction. We can find positive test or air conduction more than bone conduction in normal hearing or in sensory neural hearing loss. In sensory neural hearing loss, air conduction is better than bone conduction with Rhine test. It is positive finding. We say Rhine test is negative if it is bone conduction is better than air conduction. Usually, negative test we find in conductive type of hearing loss. Weber test. When we perform Weber test, tuning fork should be placed on the middle of the forehead. And then we ask from the patient from which side they can hear loudest. In unilateral sensory neural hearing loss, the finding is sound is localized to the unaffected side. In unilateral conductive deafness or unilateral conductive hearing loss, the finding is sound is localized to the affected side. So you can get MCQ questions from these areas. This is the summary of Rhine and Weber test. In normal hearing, Rhine test air conduction more than bone conduction in both sides. Yes, and Weber test, the finding is medium. And conductive hearing loss, Rhine test, bone conduction is more than air conduction in affected site. And air conduction is more than bone conduction in unaffected site. Weber test in conductive hearing loss lateralized to the affected site. And Rhine test in sensory neural hearing loss, air conduction more than bone conduction in both sides. Weber test in sensory neural hearing loss, the sound lateralized to the unaffected side. I think this is clear. If you have any questions, you can ask. Okay, these are the answers for sixth question. When investigating patients with hoarseness, a chest X-ray should be considered. It is true because apical lung cancers, patients with apical lung cancers can be presented with hoarseness reports. And metastasis to the brain is a common in malignant otitis externa. It is false because malignant otitis externa is not a malignant or cancerous type of disease. It is a type of otitis externa and due to the infection of sebum. And sudden sensory neural hearing loss should be treated with low-dose prednisolone. Actually, sudden sensory neural hearing loss should be treated with prednisolone or intratympanic steroids, but not low dose. It should be high dose. And bone conduction better than air conduction in positive Rhine test. It is false. Positive Rhine test means air conduction better than bone conduction. And we can find positive Rhine test in normal hearing as well as in sensory neural type of hearing loss. In bone conduction, bone conduction type of hearing loss, you can see bone conduction is better than air conduction. In bone conduction is better than air conduction in conductive type of hearing loss. And progressive hearing loss is a feature of Meniere's disease. It is true. It is sensory type of hearing loss. And seventh question, which one of the following true or false regarding acute otitis media? Antibiotics should be started as soon as possible to prevent complications. What do you think? Should we start antibiotics for patients who present with otitis media at very first day or initial phase? What do you think? Ear discharge is the most common presenting complaint. Bulging tympanic membrane is an otoscopic finding. Patients should be advised to seek medical help if the symptoms worsen or do not improve after 7 days. Antibiotics should be prescribed immediately if symptoms lasting more than 4 days or not improve. Please see the explanations. Acute otitis media, it's a very common presentation in our day-to-day practice. It is common among young children. The clinical features and diagnosis is most of the time children present with otalgia. And some children may have tap or rub their ears. Fever usually associated feature around 50% of cases, and hearing loss also a possibility. Conductive type of hearing loss is also a possibility. And usually follows the recent viral upper respiratory tract infections. And not all acute otitis media have ear discharge. Ear discharge is a feature if tympanic membrane perforates. Possible otoscopy findings in acute otitis media. Bulging tympanic membrane is a feature. So then loss of light reflex is also a feature of acute otitis media. Pacification or erythema of tympanic membrane. Perforation of tympanic membrane with purulent otorrhea is a possibility. And decreased mobility if you see pneumatic otoscope. So you can get questions regarding otoscopic findings of acute otitis media. The management of otitis media. Actually, the acute otitis media is the cause is most probably viral. So all patients with acute otitis media, generally it is self-limiting condition, but they do not require antibiotic from for initial phase of treating acute otitis media, because it is most probably the origin is viral. And we have to give some analgesics to relieve ear pain. And we have to clearly do safety netting. We have to advise parents of the ill children. We have to ask them to review in 3 days' time to assess the improvement. And if there is no improvement after 3 days, we have to prescribe antibiotics, assuming a secondary bacterial infection in ear. If you start antibiotic, first choice is amoxicillin. You have to give 5 to 7 day course for that. If patients are allergic to penicillin, you can prescribe erythromycin or clarithromycin. The complications of otitis media. Otitis media, the eardrum can be perforated and ear discharge is a result. And unresolved acute otitis media can develop into chronic suppurative otitis media with ruptured tympanic membrane and persistent ear discharge. And we defined chronic suppurative otitis media as perforation of tympanic membrane with otorrhea for more than 6 weeks. And there may be associated features of hearing loss. Mastoiditis is a complication of otitis media, meningitis, brain abscess, facial neurosis, and there may be other complications as well. So please read around otitis media. The management of otitis media. So as I told you, we usually do not treat all patients with antibiotics in acute otitis media. But we have to start antibiotic immediately after diagnosis of otitis media if symptoms lasting more than 4 days or not improving. And systemically unwell patients with high fever and poor oral intake, those things. And we have to start antibiotics immediately for immunocompromised patients, like splenectomized patients and patients who have heart or lung, kidney or liver or neuromuscular disease complications. And children with younger than 2 years with bilateral otitis media is an indication for antibiotic treatment in acute otitis media. And otitis media with perforation or discharge in the canal is another indication for antibiotic treatment. So answers for 7th question. Antibiotics should be started as soon as possible to prevent complications of otitis media. It is false because it is origin is viral. You can wait 3 days. So if it is not resolving after 3 days, we have to start antibiotics. Ear discharge is the most common presenting complaint in otitis media. It's false. Most common complaint is ear pain, not ear discharge. But you can see ear discharge in patients with otitis media after perforation of the tympanic membrane. Bulging tympanic membrane is an otoscopic finding. It is true. Parents should be advised to seek medical help if the symptoms worsen or do not improve after 7 days. It is false. Actually, we need to review patients in 3 days' time, and we have to start antibiotic if they do not show any improvement. And after 7 days is false, after 3 days is correct. Antibiotics should be prescribed immediately if symptoms lasting more than 4 days or not improving. It is true. It is maybe due to secondary bacterial infection. Eighth question, which of the following true or false regarding nasal septal hematoma? So nasal septal hematoma is also a very important topic in primary care because so you can get questions from this area. So try to find the answers altogether for this question. Bilateral nasal septal hematoma is common than unilateral. Bilateral is common than unilateral. Watchful waiting is the best management. Nasal septal perforation is not a complication. Delayed treatment increases the risk of septal abscess. Expanding hematoma results in avascular necrosis of the septal cartilage. We'll see the explanations. Nasal septal hematoma usually occurs with nasal trauma. Even with minimum trauma also can cause nasal septal hematoma. And it is a development of hematoma between the septal cartilage and the overlying pericondylium. Patients usually complain about the nasal obstruction, and it is the most common symptom. And some patients complain about the pain and rhinorrhea. And on examination, the classical finding is bilateral red swelling arising from the nasal septum. If you do not have facilities to examine nasal septum, you need to refer those patients to exclude this condition. The management is surgical drainage and then start intravenous antibiotics. If we do not treat for this condition, or if untreated, irreversible septal necrosis may develop within 3-4 days. Okay, so this is due to the pressure-related ischemia of the cartilage, resulting necrosis. So, as a result of that, patients may develop saddle nose deformity. It is irreversible condition. So, I think you can see. Okay. Complications of untreated nasal septal hematoma. There are other complications like septal abscess, saddle nose, deviation of nasal septum, facial cellulitis, orbital or periorbital cellulitis, intracranial complications like cavern sinus thrombosis, abscesses, and meningitis. So you have to remember that nasal septal hematoma should be drained urgently to avoid undue complications. Therefore, you have to refer those patients to secondary or ENT care if you suspect nasal septal hematoma. Okay, so answer for 8th question. Which one of the following true or false regarding nasal septal hematoma? Bilateral nasal septal hematoma is common than unilateral. Yes, it is true. Bilateral is most common than unilateral septal hematoma. Watchful waiting is best management. It is false. We have to refer urgently to drain the hematoma. And nasal septal perforation is not a complication. It is false. Nasal septal perforation is a complication of nasal septal hematoma. And delayed treatment increased risk of septal abscess. It is true. Expanding hematoma results in avascular necrosis of the septal cartilage. It is also true. That's why we have to refer them urgently to evacuate or drain the hematoma. Which one of the following condition cause halitosis or bad breath? Spicy foods, end-stage renal failure, gastroenteritis, treatment with nitrate medications, and dental prosthesis. You can get questions from halitosis in MCQs, as well as you may get osteocases as well. So halitosis is an unpleasant, disagreeable, offensive breath odor, or we use the term of bad breath for explain halitosis. These are the common causes for that condition. Problems within mouth or disorders or the conditions in the nose and throat, and systemic diseases related with dry mouth and diabetes and systemic sclerosis like that, and physiological consideration, dehydration and those things. And some drugs also can cause certain type of foods and psychological disorders also related with these health issues. And all the answers are correct in that question. So, 10th, last question. Which one of the following true or false regarding allergic rhinitis? Actually, this is very, very common presentation. So, I think you need to read around. There's a chance for you to get questions from this area. Try to find the answers altogether. It can be associated with allergic conjunctivitis. Prolonged use of topical nasal decongestant is an effective treatment. Intranasal corticosteroids can be used for moderate to severe persistent symptoms. Patients with bloodstained nasal discharge should be referred. Radiological imaging is routinely recommended. So you also try to find the answers. Or if you want to discuss, anyone can answer for this question. Okay, so allergic rhinitis. Allergic rhinitis is an inflammatory disorder of the nose. And the nose becomes sensitized to allergens such as house dust mites, grass, tree, and weed pollens. So allergic rhinitis, there is a classification. Seasonal allergic rhinitis, symptoms occur around the same time every year. Secondary to pollens, we called it as hay fever. Perennial type of allergic rhinitis occur throughout the year. And occupational allergic rhinitis, symptoms follow exposure to particular allergens within the workplace. So allergic rhinitis features are sneezing, bilateral nasal obstruction, clear nasal discharge, post-nasal drip, and nasal pruritus. So all patients, we have to examine for nasal polyps in allergic rhinitis because it is also a common association. Management of allergic rhinitis, you have to avoid allergen to expose. If the person has mild to moderate or intermittent or mild persistent symptoms, you can try with oral intranasal antihistamines. But if the patient's quality of life reduces with this problem, or if the patients have moderate to severe persistent symptoms, you have to try with intranasal corticosteroid spray. And there may be a short course of topical nasal decongestant like oxymetazoline. But remember, you should not treat patients with prolonged periods with oxymetazoline or nasal decongestants. It increases the doses required to achieve the same effect. When you need to give it again, you have to give higher doses to get same effects, or we call it as tachyphylaxis. And the rebound hypertrophy of the nasal mucosa is another problem with prolonged use of nasal decongestant. And we call this condition as rhinitis medicamentosa. Patients get symptoms again upon the withdrawal of nasal decongestant. So answer for this last question, allergic rhinitis can be associated with allergic conjunctivitis. It is true. Allergic rhinitis can be associated with allergic conjunctivitis, bronchial asthma, and eczemas, and those things. And prolonged use of topical nasal decongestant is an effective treatment. It is false. We should discourage prolonged use of topical nasal decongestant to avoid these conditions like rhinitis medicamentosa and tachyphylaxis. Intranasal corticosteroid can be used for moderate to severe persistent symptoms. It is true. And patients with bloodstained nasal discharge should be referred. It is true because we need further evaluation to exclude certain things. And radiological imaging is routinely recommended. It is false. For all patients, we do not need a radiological evaluation. So if you have any questions, you can ask. And if you do not have any questions, we can stop, and good luck for your upcoming exams. Okay. Sorry, I couldn't put the slides. I will tell the answers. The HINTS test must be performed on patients suspected of central vertigo with persistent symptoms. It is true. We use this test to exclude or identify central vertigo. And the nystagmus is central vertigo is always unidirectional. It is no. Actually, in central vertigo, the nystagmus is maybe bidirectional or vertical. Central vertigo is the most predominant symptom of posterior circulation stroke. It is true. Posterior circulation strokes actually they present sometimes without any neurological manifestations like weakness or reduced sensation, those things. They usually present with vertigo, vomiting, imbalance of the body like that. And it is true. Central vertigo is a predominant symptom of posterior circulation stroke. That's why we, in our primary care setups, we do HINTS test at least to differentiate central causes from peripheral causes. Vestibular migraine is a cause for central vertigo. It is true. And patients with vertical nystagmus can be reassured. It is false because vertical nystagmus is always pathological and it cause for central cause of vertigo. And first one is, I think, are you clear? And do I need to explain the answers again? Hello? First one is true. Second one is false. Third one is true. And fourth one is true. Fifth one is false. Okay.
Okay, madam.
Okay. And third question, I will give few minutes, seconds to read and answer the questions. Which of the following statement is correct concerning tinnitus? Tinnitus is the perception of sounds in the ears or head that come from an outside source. True or false? Come from an outside source. And second one is magnetic resonance angiography is often used to investigate, sorry, there's a printing mistake, investigate pulsatile tinnitus. True or false? Captopril can be a common cause of tinnitus. Cognitive behavior therapy is useful for some patients. Generally, non-pulsatile tinnitus does not require imaging. What do you think? Can someone tell the answers to us?
First one true, second one false, third one true, fourth one true, fifth one true.
Okay, we'll see the descriptions and come to the answers last. Tinnitus or ringing ear. Have you experienced this? What do you think? Tinnitus is the perception of sound in the ears or head that do not come from an outside source. It is the problem with the inside, not outside. Not all patients will require imaging because the causes of tinnitus, it has wide range. Most of causes are benign and self-limiting. So not all patients require imaging. But so non-pulsatile tinnitus does not require imaging, but unilateral or pulsatile type of tinnitus we have to imagine because it can be due to the vascular causes, vascular malformations or high blood pressure, aneurysms, those things. So if patients complain about the pulsatile type of tinnitus, if it is unilateral, we have to refer those patients for neurological. For pulsatile tinnitus, we have to investigate with magnetic resonance angiography or MRA. So these are the common causes of tinnitus. Meniere's disease, as I told you earlier, it is the patient's complain about the fullness or pressure in one or both ears. In otosclerosis, this is actually this is familial type genetic disorder, inheritance as an autosomal dominant manner. Patients are usually young age, within 20 to 40 years. They have hearing loss. It is conductive type of hearing loss, present with conductive type of hearing loss, tinnitus, and there, but this is also important. Majority of patients have normal tympanic membrane, but 10% of patients have flamingo tinge caused by hyperemia. I will show a picture in which type of changes in the tympanic membrane in patients with otosclerosis. As I told you, it is autosomal dominant inheritance. And acoustic neuroma, patients present with sudden onset of sensory neural hearing loss and with vertigo and tinnitus. This also I have mentioned earlier, absent corneal reflex and associated with neurofibromatosis type 2 most of the time. And excessive light noise also cause for tinnitus. Or old age, hearing loss due to old age or presbycusis, also complain about the tinnitus. And impact of earwax. For some patients, actually, we do not know the cause. Impact of earwax, it is a hearing loss, a conductive type of hearing loss is there. So actually patients who have tinnitus, they are very distressed and they have psychological and social problems with that issue. So we always, when patients present with tinnitus, we have to assess their psychosocial aspects because some patients are very depressed and at that time we have to ask about the suicidal ideas as well. So some drugs also can cause tinnitus, furosemide, aspirin, aminoglycoside, and quinine. But captopril is not a common cause for tinnitus. These are the common drugs can cause tinnitus. And the first one is tinnitus is the perception of sounds in the ear or head that come from an outside source. It is false. And MRA is often used to investigate pulsatile tinnitus. It is true to exclude vascular causes, vascular malformations, or aneurysms like this. And captopril is a common cause of tinnitus. It is false. It's not a common cause. And cognitive behavior therapy is useful for some patients. So the cognitive behavior therapy is to help them to learn how to live with this problem. Sometimes the tinnitus we cannot reverse. So we use that mask, tinnitus mask for some patients, but cognitive behavior therapy is also effective for patients with tinnitus to improve their quality of life. And generally non-pulsatile tinnitus do not require imaging, it is true. Do you have any problems, or shall I move to next question? This is fourth question regarding cholesteatoma. You can get questions from these areas. Sometimes you are not familiar with these things, but you have to read. What is true or false concerning cholesteatoma? It is a malignant condition with destruction of the skull bone. What do you think?
False.
Okay. Recurrent false spelling ear discharge is a common feature.
True.
Sensory neural hearing loss is a characteristic feature.
False.
Okay. Facial palsy is due to bone destruction.
False.
Okay, we'll see. Attic lesion is otoscopic finding in the middle part of the eardrum.
True.
Okay, we'll see about this. Cholesteatoma, it is non-cancerous growth of squamous epithelium. But there is a local destruction of bone. But it is not malignant, but there is a local destruction of bone. So patients who born with cleft palate, they have high risk of develop cholesteatoma. The main features of cholesteatoma is false smelling, non-resolving persistent discharge. And they have hearing loss. It is conductive type. And other features due to local invasion, due to bone destruction, vertigo, facial nerve palsy, cerebellar-pontine angle syndrome also rare findings. Otoscopy for attic crust seen in the uppermost part of the eardrum. So the attic lesions you can see not in the middle part, uppermost part of the eardrum. So management is we have to refer these patients to ENT for surgical removal. So this is cholesteatoma. So answer, this is not malignant condition, but destruction of skull bone is there, but not malignant. So this is false. First one, recurrent false near discharge is common feature. This is true. And sensory neural hearing loss is a characteristic feature. It is false because this is conductive type of hearing loss is in cholesteatoma patients. Facial palsy is due to bone destruction. It is true. Attic lesion is, but this is rare. This is very rare finding. Attic lesion is prominent otoscopy finding in the middle part, not in the middle part, uppermost part of the eardrum. So this is false. This is our fifth question. Which one of the following statement is true or false? First one, intranasal steroid therapy is effective treatment for 4 months history of nasal congestion of affecting right nostril. It means only one side. What do you think? With topical antibiotic and steroid combination would be appropriate management for otitis media. Chronic suppurative otitis media is defined as perforation of the tympanic membrane with otorrhea for more than 2 weeks. Sudden onset sensory neural hearing loss requires urgent referral to ENT. Hearing loss can be a feature of viral labyrinthitis. So let's talk a little about nasal polyps. Nasal polyps usually associated with asthma or bronchial asthma or aspirin sensitivity, infective sinusitis, cystic fibrosis, cartilaginous syndrome, and Church-Strauss syndrome. So sometimes you may get questions from this area, nasal polyps and common associations. And the features of nasal polyps, nasal obstruction is the most common complaint. Rhinorrhea, sneezing, and poor sense of taste and smell are the other common features of nasal polyps. This is important point. Unusual features which always require further investigation include unilateral symptoms or bleeding. If patients present with unilateral symptoms of nasal obstruction, rhinorrhea, or poor sense and smell only one side of the nostril, or bleeding, we always refer to ENT for further assessment because it may be related with some serious problems. So nasal polyps, all patients with suspected nasal polyps should be referred to ENT for full examination. And topical corticosteroids we can use for nasal polyps to shrink polyp size in around 80% of patients. So, but we have to refer them for ENT, and we can use corticosteroid nasal sprays to shrink polyp size. And little about the management of otitis externa. So I think you have to read around these areas, otitis externa, otitis media. I have put the important points only in here. And management of otitis externa, topical antibiotic or combined topical antibiotic with steroids we can use. If the tympanic membrane is perforated, we can use antibiotic. If tympanic membrane is perforated, we usually not use aminoglycosides. And if there is a canal debris, we have to remove that. Otitis externa can be present with canal debris and ear canal swelling, and we have to remove canal debris. So usually it should be done in the ENT. They have special instruments for that. So if the canal is extensively swollen, then we can use ear wick. So these are the management things. Sometimes you may get questions from these areas. And chronic suppurative otitis media, unresolved with acute otitis media with perforation may be developed into chronic suppurative otitis media. So it defined as the perforation of tympanic membrane with otorrhea for more than 6 weeks. So patients with otitis media can develop chronic suppurative otitis media with rupture of the tympanic membrane or perforation of the tympanic membrane. So we defined this condition as perforation of tympanic membrane with otorrhea for more than, if it is persist more than 4 weeks. So I will touch little about the hearing loss. So hearing loss, there are two types, conductive and sensory neural. So conductive, most common type causes for conductive hearing loss, otitis media, foreign bodies, otosclerosis, cholesteatoma, fluid in the middle ear, or perforated tympanic membrane, or station tube dysfunction. I'm sorry for the mistake. And sensory neural hearing loss, common causes due to elderly age, Ramsey-Hunt syndrome, acoustic neuroma, sometimes no cause for sensory neural hearing loss, Meniere's disease, acute labyrinthitis, and exposure to loud noise. So I think the causes are also important for hearing loss, so remember these things. This is important, sudden onset of hearing loss. So when a patient presents with sudden onset of hearing loss, so first we have to differentiate whether this is due to conductive hearing loss or sensory neural hearing loss. So if it is sensory neural hearing loss, we have to refer these patients urgently to ENT units because sometimes those patients need MRI scans to exclude vestibular schwannoma or tumors. And actually, the common cause for sensory neural hearing loss is idiopathic. Now, the research says that high-dose oral corticosteroids are effective to treat sensory neural hearing loss. So, to give this, actually, we give these high-dose oral corticosteroids or intratympanic steroids also we can give, not we, actually, in primary care setup. We refer patients to ENT units to start intratympanic corticosteroids. I think it is the most effective way to treat sudden onset of hearing loss, sensory neural hearing loss. Surely I have shared this. Shall I share this presentation again? I think I have shared my old one. Can you hear? Yeah, can you hear me? Hello?
Can hear you, madam, but
Oh.
can't see the screen.
Can't see, no? Okay. So, now, can you see the slides? Hello?
Yes, madam, can see.
Ah, sorry for the delay. Technical problem. Do you have any problems with sudden onset of hearing loss, or do you want more explanation? I wanted you to tell that sudden onset of hearing loss, we have to differentiate it whether it is conductive or sensory neural. If it is sensory neural, we have to refer them to ENT urgently to get high dose of oral corticosteroids or intratympanic corticosteroids. Okay. Which one of the following statements is true? When investigating patients with hoarseness, a chest X-ray should be considered. True or false? Metastasis to the brain is a common in malignant otitis externa. Sudden sensorineural hearing loss should be treated with low-dose prednisolone. Bone conduction better than air conduction in positive Rhine test. Progressive hearing loss is a feature of Meniere's disease. Can someone tell the answer? So, these are the common causes of hoarseness of voice. I think voice overuse, smoking, viral illness, hypothyroidism, gastroesophageal reflux, pharyngeal cancers, lung cancers. And I think you can go through these. And there are rare causes as well. But in primary care setups, these are the common causes we usually think about. And have you heard about malignant otitis externa? Surely it is not a malignant condition. It is due to infection. It's an uncommon type of otitis externa. If we do not treat otitis externa properly, it can go into malignant otitis externa condition of usually found in immunocompromised patients, especially diabetes. So that's why we have to treat otitis externa very carefully. So malignant otitis externa is a serious condition. Actually, we have to admit and give IV antibiotics to treat those patients. The most commonly due to the Pseudomonas aeruginosa. And so this infection actually we have to treat with IV antibiotics. Otherwise, it can be end up with temporal bone osteomyelitis. The patient complained very severe and very deep otalgia or ear pain and temporal headache, purulent otorrhea, discharge from the ear, and it can be associated with difficulty in swallowing or voice change. And we have to, that's why if we treat otitis externa, we should treat it very carefully. If we think it is not resolving, we have to refer those patients urgently to ENT. So these patients need intravenous antibiotics to cover the Pseudomonas infection. Otherwise, it will end up with osteomyelitis. So Meniere's disease also a common area for MCQs. It is the patients complain about the excessive pressure and feeling of ear fullness due to progressive dilatation of the endolymphatic system. It is common in the middle age, but we can see patients at any age. And recurrent episodes of vertigo, tinnitus, and hearing loss. The hearing loss is sensory neural in this Meniere's disease. Vertigo is also a common symptom. Sensation of oral ear fullness, pressure. This is the most common complaint of the patients. And nystagmus, positive Romberg test, also a possibility. Usually last 20 minutes, but sometimes episode lasts minutes to hours, but not days, minutes to hours. Typically symptoms unilateral, but sometimes give bilateral symptoms. This is progressive type of disease. The hearing loss is also progressive, but it developed over many years. Slowly progressing disease, major of patients present after 5 to 10 years of the illness. Sensory neural hearing loss is the common. And these patients also, they are also very distressed and associated with psychosocial problems. And we have to refer these patients to ENT for further assessment and the treatment. In acute attack, actually, we can treat with propionephrine. Sometimes we have to admit these patients. And to prevent this condition, we can use beta histine and vestibular rehabilitation. And sometimes you may get questions from this area, so read around. Another condition of hearing loss, otosclerosis. This gives conductive type of hearing loss due to spongy bone is the problem. Development of the spongy bone or softness of the bone. And progressive conductive deafness is the feature. This is autosomal dominant type. Inheritance, conductive deafness, and tinnitus is a common complaint with hearing loss. And that tympanic membrane is normal. But 10% have flamingo tinge caused by hyperemia. Positive family history is there because this is autosomal dominant type. This is a picture of otosclerosis tympanic membrane. And when we talk about the hearing loss, I think you must familiar with the Rhine and Weber test. Rhine and Weber test, we used to differentiate conductive hearing loss and sensory neural hearing loss. So to perform Rhine and Weber test, we should use tuning fork, 512 Hertz. This type of tuning fork we must use to assess the hearing. Sorry. And we should avoid using 128 Hertz and 256 Hertz tuning fork. We use this type of tuning fork to assess vibration sensation in neurological examination. So you can get MCQ from this area. Which type of tuning fork you have to use for Rhine and Weber test. So Rhine test, I think you are familiar with testing hearing, but in this Rhine test, we placed tuning fork in the on the mastoid process until sound is no longer heard, followed by repositioning just over external acoustic meters. I think better to see a video so you can get a better understanding about this. And positive test means, Rhine positive test means air conduction is better than the bone conduction. This is normal positive test means air conduction is better than the bone conduction. Negative test means bone conduction is more than air conduction. Usually, we can see this in conductive type of hearing loss. Sorry, not sensory neural deafness. This is a mistake. Negative test means bone conduction more than air conduction in conductive type of hearing loss. This is a mistake, not in sensory neural deafness. In sensory neural deafness, air conduction more than bone conduction. Are you clear about this? Rhine positive means air conduction more than bone conduction. You can see in sensory neural hearing loss and in normal condition as well. But bone conduction more than air conduction is a feature of conductive hearing loss. Weber test, tuning fork placed on the middle of the forehead. Patient is then asked which side is loudest. So unilateral sensory neural deafness, sound is localized to the unaffected side. In unilateral conductive deafness, sound is localized to the affected side. So you can get questions in this area. So this chart will help you to find the answers. Rhine test and Weber test. Normally, if normal situation, air conduction is more than bone conduction in both sides, and Weber side is we place the tuning fork midline equally hearing from both sides. But in conductive hearing loss, Rhine test bone conduction more than the air conduction in affected side, and air conduction more than bone conduction in unaffected side. And Weber test localized to the affected site in conductive hearing loss. And Weber test lateralized to the unaffected site in sensory neural hearing loss. Really think about that, and some, otherwise you may confuse it. when we look at the answers, when investigating patient with hoarseness, a chest X-ray should be considered. It is true because lung apical lung cancer patients can be presented with hoarseness of voice. So chest X-ray we have to take. Metastasis to the brain is common in malignant otitis externa. It is false. This is not a malignant condition. This is an infection. So no metastasis occur with this, and it is false. Sudden sensory neural hearing loss should be treated with low dose prednisolone, not low dose. High dose is required for treatment. And bone conduction better than air conduction, it is false. Bone conduction better than air conduction is it means it's a negative finding of Ryan text. Progressive hearing loss is a feature of Meniere's disease. It is true. Sensory neural hearing loss, it is progressive type in Meniere's disease.
So, madam, we couldn't discuss the answers to question number 5.
Number 5, okay. Lisa.
Madam, can you show the answers to question number 5?
Sorry. Okay, I didn't put that. Okay, I will explain. So in this intranasal steroid therapy is effective treatment for 4 months history of nasal congestion affecting right nostril. Actually, this is false because this is unilateral symptoms. Nasal congestion is only one side. So actually, we have to refer this patient for ENT assessment. Intranasal steroid therapy, we can use for nasal congestions, but not for unilateral. I think, are you clear about that? This patient we have to refer. Oh, so the first one is false. A topical antibiotic and steroid combination would be appropriate management for otitis media, not otitis media, otitis externa. This is also false. Second, chronic suppurative otitis media is defined as perforation of the tympanic membrane with otorrhea for more than 2 weeks. Usually this is more than 4 weeks. It is also false. Sudden onset sensory neural hearing loss requires urgent referral to ENT. It is true because those patients need high dose of steroid and intratympanic steroids. Hearing loss can be feature of viral labyrinthitis. It is true. Okay then. Sorry, I couldn't put the answer slides. You want to explain again?
No, madam.
No, madam. No.
Okay. Seventh question, which one of the following true or false regarding acute otitis media? So otitis media is also a common presentation to primary care. So read around carefully in this area. Antibiotics should be started as soon as possible to prevent complications. True or false? Ear discharge is the most common presenting complaint. Bulging tympanic membrane is an otoscopic finding. Parents should be advised to seek medical help if the symptoms worsen or do not improve after 7 days. Antibiotics should be prescribed immediately if symptoms lasting more than 4 days or not improved. We see what is acute otitis media, extremely common in young children. Clinical features and diagnosis. These are the features. Otalgia is the most common complaint, not ear discharge. Otalgia is the most common complaint. And some children, small children, may tug or rub their ear. Fever occurs in around 50% of cases. Hearing loss is also a possibility. Recent viral upper respiratory tract infection symptoms also common. Usually, these children present after upper respiratory tract infections. Ear discharge may occur if the tympanic membrane perforates, but ear discharge is not a main and initial presenting complaint. Ear pain is the most common presenting complaint. And otoscopic findings. Bulging tympanic membrane is a common otoscopic finding, and loss of light reflex. Opacification or erythema of the tympanic membrane. Perforation with purulent otorrhea. When otitis media, when tympanic membrane is perforated, these patients may present with purulent ear discharge. And decreased mobility of the tympanic membrane is another findings. This is frequent MCQ top points. You can get more questions from this area. This is very important. What are the otoscopic findings? So management of otitis media, actually the otitis media common cause is viral. So sometimes it is a self-limiting condition actually. We do not require any, we should not start any antibiotics in initial phase because the cause is viral. But we have to give pain relieving drugs for pain, ear pain. But we have to clearly advise parents of the child to seek medical help if symptoms worsen or do not improve after 3 days. This safety netting is very, very important. But if the symptoms not resolved after 3 days or usually after 4 days, we have to start antibiotics. Amoxicillin is the first line drugs. We have to treat 5 to 7 days course. We can use erythromycin and clarithromycin if they are allergic to penicillin. Otitis media give complications. Perforation of tympanic membrane and otorrhea is one, not a complication actually. And unresolved acute otitis media with perforation can develop into the chronic suppurative otitis media. And chronic suppurative otitis media is a perforation of tympanic membrane with otorrhea for 6 weeks. This is also important statement for MCQ. And these patients complicated with hearing loss, labyrinthitis, mastoiditis, meningitis, brain abscess, facial nerve palsy. There are a lot of complications. That's why we ask patients to come after 3 days and treat with antibiotics if it is not resolved within 3 days. For some patients, we have to start antibiotics immediately. This is also important MCQ point. Symptoms lasting more than 4 days or not improving symptoms. Systemically unwell, but not requiring admission. Some patients, they have high fever and not eating nor drinking, but not in admission criteria. Anyway, we have to start oral antibiotics and review frequently. For immunocompromised patients with splenectomy or heart or lung, kidney or chronic diseases, we have to start antibiotics from very first day. And patients with younger than 2 years with bilateral otitis media is another indication for antibiotic treatment. Otitis media with perforation and or discharge in the canal. If patients with otitis media with perforation of eardrum and ear discharge, so at that situation, we have to start antibiotics. So answers for that question, antibiotics should be started as soon as possible to prevent complications. It is false because cause is viral. So we can wait 3 days with self-tinnitus. Ear discharge is the most common presenting complaint. It is false because ear pain is the most common presenting complaint. Bulging tympanic membrane is an otoscopic finding. It is true. Parents should be advised to seek medical help if the symptoms worsen or do not improve after 7 days. It is false. This should be 3 days. Antibiotics should be prescribed immediately if symptoms lasting more than 4 days or not improving. It is true. Eighth question.
Madam, is topical antibiotics indicated in otitis media?
No. Topical antibiotics we used in otitis externa, not otitis media. Otitis media is a problem with the middle ear. So preserve, when we use otitis antibiotics, if the tympanic membrane is ruptured, then we can use antibiotics. But with preserved tympanic membrane with otitis media, is no point to give topical antibiotics because it is a problem with the middle ear. Topical antibiotics we used to treat otitis externa.
Okay.
Okay.
Thank you.
Okay. Which of the following true or false regarding nasal septal hematoma? Bilateral nasal septal hematoma is actually I have got this type of question sometimes back when I was doing the MRCGP. If you are targeting the MRCGP also, this is a common topic. Nasal septal hematoma. Bilateral nasal septal hematoma is a common than unilateral. True or false? Watchful waiting is the best management. Nasal septal perforation is not a complication. Delayed treatment increases the risk of septal abscess. Expanding hematoma results in avascular necrosis of septal cartilage. So, read around septal hematoma. Nasal septal hematoma is an important complication of nasal trauma. Even minor nasal trauma also can end up with nasal septal hematoma because this is very sensitive area. It describes the development of hematoma between the septal cartilage and the overlying perichondrium. Sensation of nasal obstruction is the most common symptom, and pain and rhinorrhea also seen. On examination, bilateral red swelling arising from the nasal septum is a common examination finding. So management, we have to surgical drainage urgently and treat. Sometimes we have to treat intravenous antibiotics with intravenous antibiotics if we think it can end up with the nasal septal abscess. Otherwise, surgical drainage is must. If we untreated with surgical drainage, it can end up with irreversible septal necrosis within 3-4 days. This is due to pressure related ischemia of the cartilage, resulting in necrosis. This may result in a saddle nose deformity. This is irreversible condition. That's why we have to treat nasoseptal hematoma very carefully. Complications of untreated nasoseptal hematoma, local septal abscess, saddle nose, deviation of nasal septum, facial cellulitis, orbital or periorbital cellulitis, intracranial complications, cavernous sinus thrombosis, epidural abscess, even meningitis. So remember that nasal septal hematoma should be drained urgently to avoid undue complications. In primary care setup, we have to refer these patients without treating, keeping in our settings. We have to refer those patients for surgical drainage. So bilateral nasal septum hematoma is common than unilateral. Bilateral is common. It is true. Watchful waiting is the best management calls. We have to refer them for surgical drainage. Nasal septal perforation is not a complication. It is false. It is a complication. Delayed treatment increase the risk of septal abscesses in true. Expanding hematoma resulting in avascular necrosis of the septal cartilage. It is true. Which one of the following conditions causes halitosis or bad breath? Spicy foods, end-stage renal failure, gastroenteritis, treatment with nitrate medications, dental prosthesis. Actually, this is also a common presentation to primary care setup. Halitosis is unpleasant, disagreeable, offensive breath odor, or we use the term of bad breath to explain halitosis. These are the common causes. I think you can go through that. There are many causes. Causes inside the mouth, dental caries, and dental issues. And nasal and throat problem also a possibility, and systemic diseases with the dry mouth, like systemic sclerosis, diabetes, and drugs and dehydration of some foods and psychological disorders. I think you go through these slides and all the answers are correct in this question. Even you can get OSCE cases also with halitosis. Our last question, which one of the following true or false regarding allergic rhinitis? It can be associated with allergic conjunctivitis. Prolonged use of topical nasal congestant is an effective treatment. Intranasal corticosteroid can be used for moderate to severe persistent symptoms. Patient with bloodstained nasal discharge should be referred. Radiological imaging is routinely recommended. Someone want to answer? Allergic rhinitis is also very common presentation. It is an inflammatory disorder of the nose nose becomes sensitized to allergens such as house dust, mites, and grass, tree and weed pollens. There are several types. Seasonal ones, symptoms occur around the same time every year. Due to seasonal rhinitis occurs secondary to pollens and we use the term of hay fever. And perennial symptoms occur throughout the year. And occupational allergic rhinitis symptoms follow exposure to particular allergens within the workplace. And features are sneezing, bilateral nasal obstruction, clear nasal discharge, postnasal drip, and nasal pruritus. But we have to look inside the nose to exclude nasal polyps of these patients. Management of rhinitis, allergen avoidance is very, very important. If the patient has mild to moderate, intermittent or mild symptoms, we can use oral or intranasal antihistamines. But if patients have persistent, moderate to severe symptoms, and if the patient's quality of life reduced with this problem, we can use intranasal corticosteroid sprays. So there is a place for short course of topical nasal decongestants like oxymethicillin. But we should not use them long term because prolonged use of oxymethicillin or nasal decongestants can give effects of rebound hypertrophy of the nasal mucosa and the symptoms reappear or severe symptoms patients get on withdrawal of the topical nasal oxymethicillin. So we call this condition as rhinitis medicamentosa. This rebound problems you get with withdrawal of the when you stop the nasal decongestants after prolonged use, patients get again severe or persistent symptoms of rhinitis on withdrawal. So answers, which are one of the following true or false regarding allergic rhinitis can be associated with allergic conjunctivitis? It is true. Even bronchial asthma, also the possibility, and skin eczemas, those things. And prolonged use of topical nasal congestant is an effective treatment. It is false. I think you know that. Rebound problems and withdrawal things, rhinitis medicamentosa like problems can develop with this. And intranasal corticosteroid can be used for moderate to severe persistent symptoms. It's true. Patients with bloodstained nasal discharge should be referred. It is true because we should exclude other things, even nasal cancers and polyps, those things we have to exclude. And radiological imaging is routinely recommended. It is false. This is actually clinical history is most important thing. So if we suspect with other things like unilateral symptoms, nasal discharge, only we have to investigate further. If you have any questions, you have any questions? Okay. It's boring. I think it's better to read around all the topics